Hello, I'm Dr. Chad Price, the Medical Director of the International Hip Dysplasia Institute. This is a discussion for primary care physicians and pediatricians regarding the diagnosis and referral of infantile hip dysplasia. This is prepared in association with my colleagues in the International Hip Dysplasia Institute from around the world, and we have developed, with their help, some validated educational materials and even some testing if you desire that. I have no financial conflicts of interest. This is part one, diagnosis and referral. Part two is actually treatment and early initial non-surgical management, if you care to get into that. But this will just be part one. We'll talk about anatomy and pathology. Some of this will be a review, clinical diagnosis, and then referral for imaging or treatment. And then we'll get into prevention a little bit at the end, some advice that you can give parents. There are two major categories of hip dysplasia. The type we'll be talking about today is newborn hip instability and dislocation. This accounts for about 10% of all hip dysplasia. It's one that occupies a lot of our attention because the hip can be completely dislocated. The second type has come to our attention in the last 15 to 20 years, is actually a stable dysplasia with a shallow socket, one that maybe didn't develop adequately at some point in time, and that may be actually around the time of birth, but it shows up during adolescence or adulthood, and it's a socket that's incomplete. This X-ray here shows a nice deep socket that's well-contained femoral head, whereas this shows a shallow socket or a dysplastic socket, and over time, this does not distribute the pressure well enough, so this one will wear out and cause early arthritis. This type of hip dysplasia and the infantile combined account for about 10% of all total hips in the United States. Now, neonatal hip instability, which we'll be talking about, is the most common abnormality in newborn infants. A dislocated hip occurs in 1 to 2 per 1,000 births in North America, but about 1 in 100 births will have some instability or a dislocatable hip, and those need to be observed. What's been learned from neonatal ultrasound is that up to 1 in 10 newborn babies has instability. Fortunately, the majority of this resolves, but this is a big problem that can be managed. A DDH is what we call it, which is developmental dysplasia of the hip, and this occurs in an otherwise healthy child. There's certainly neuromuscular hip dislocations, and it's important to tell parents that this is not a true birth defect with missing tissue. A clubfoot or cleft lip or cleft palate heart defects, they have actual defects. This is actually a stretched out ligament, and it develops at birth, or it can develop later, as you'll see. Now, childhood hip dysplasia can range from a mildly displaced joint to a completely dislocated joint. The International Hip Dysplasia Institute has developed a reliable radiographic classification that helps guide treatment for orthopedic surgeons. This classification has been validated and it's being widely used today. But there's a range of hip dysplasia all the way to hip dislocations that are irreducible. Before we get into the diagnosis, the treatment basically is in younger than 6 months, a harness or brace is used, and that's about 85% successful. We'd like it to be higher. For a completely dislocated hip, it fails about 1 in 6 times when they start less than 6 weeks of age. Between 6 months and 18 months of age, when dislocated hip is diagnosed, a reduction under general anesthesia and a body cast for about 4 months is the general recommendation. There are some surgical procedures that can be performed, and this has about a 40% success rate. So when those methods fail, then the last resort is open reduction, and this is the treatment of choice for children older than 18 months. And open reduction is a surgical procedure where the reconstruction of ligament and bones can be performed. So let's talk about the anatomy and pathology of the hip as a review.
The hip is a ball and socket joint between the pelvis and the femur. articulating between the femoral head and the acetabulum. The base of the acetabulum is C-shaped and completed inferiorly by the transverse acetabular ligament. The bone is covered in articular cartilage, and the rim augmented by a tough triangular structure known as the acetabular labrum, which deepens the socket and provides stability to the articulation with the femoral head. Surrounding the joint is a complex capsule that has 3 distinct thickenings that spiral around the joint that are loosely referred to as ligaments. These tighten up during internal rotation and extension of the joint, adding to stability in this position. A number of powerful muscles attach near the joint. The most important of these are the abductors at the greater trochanter, psoas at the lesser trochanter, and the adductors to the medial proximal femur. Capsular laxity, from whatever cause, is the most common underlying pathology in the development of hip dysplasia. This laxity may produce secondary changes in the hip, which may be well established at birth or develop in the postnatal period if the laxity persists. Capsular laxity leads to a number of pathological scenarios. Subluxation. This refers to the femoral head sliding within the acetabulum, but without completely losing contact. This is felt as a gliding sensation and may at times be difficult to appreciate. Dislocation. This is where the femoral head loses contact with the acetabulum. The femoral head may be dislocatable, able to be pushed out of the socket, or dislocated, not in the socket. Dislocations may be able to be put back in the socket, that is, reducible, or remain stuck in the dislocated position, that is, irreducible. As the unstable hip subluxates and then dislocates, changes occur to the normal anatomical structures. Understanding these changes helps with interpreting clinical signs. With the head lying laterally on the acetabular rim, the labrum and acetabular margin become flattened, and the acetabular shape deteriorates. As the femoral head moves out of the socket, the adductors become tight due to their natural line of pull being disturbed. Acetabular dysplasia specifically refers to incomplete or insufficient development of the hip socket. Such dysplasia may be due to the effect of an unstable hip, but on occasion is an isolated condition resulting in a shallow socket that does not contain the femoral head appropriately. This type of hip does not necessarily become unstable. Some hips spontaneously improve, whilst others are only identified in adult life with the development of early arthritis due to a poor mechanical environment in the joint, producing cartilage damage.
Okay, I want to thank the Royal Children's Hospital of Melbourne for that video and other videos that they've developed, along with Leo Donnan, who's the orthopedic surgeon that helped them. So we'll get on to the newborn exam. You're familiar with the Barlow and the Ortolani test. The Barlow actually forces the hip partially or completely out of the socket, whereas the Ortolani is a reduction maneuver. The hip is out of the socket and the Ortolani puts it back in. As I said, the Ortolani test reduces a dislocated hip. It's not a click or a snapping sound. It's a feeling of abnormal movement, like a car going over a speed bump. There's generally not a sound associated with it, but there is a feel associated with it. We'll go back to this Royal Children's Hospital Melbourne video that demonstrates the Ortolani test.
Both hips are flexed to 90 degrees, with the knee grasped and thigh held between the thumb and index fingers. The fourth and fifth fingers lie over the greater trochanter, and as the hip is gently abducted, these digits attempt to lift the dislocated femoral head into the acetabulum. If the test is positive, the examiner will feel a clunk as the hip reduces. If the leg is then allowed to adduct, the hip dislocates and the leg appears to shorten.
The Barlow test, in contrast, dislocates and reduces an unstable hip, or there may be a feeling of instability. You can see from this image that the infant hip is very shallow and soft. So if the ligaments aren't very tight, then it can easily be pushed in and out of this socket like a shoulder that's loose or a hip that's loose.
The examiner's fingers should lie over the greater trochanter or lateral thigh. The hip being examined is then adducted by 10 to 20 degrees. Gentle but firm backward pressure is then applied. A small amount of movement is usually detectable in the neonatal hip, which disappears after a few weeks. If the hip is dislocating, the gliding sensation is present but is followed by a distinct loss of resistance as the femoral head escapes the socket. This dislocation can be confirmed either by relaxing the pressure or by the Ortolani maneuver.
Here's a clinical demonstration of the examination, and you can see that it's very gentle and the baby tolerates it very well.
So we put our finger on the trochanter, push back just a little bit, and do the Ortolani test and just lift the hip into the socket. So it's just like that, down and out. That's the Barlow test. Now the Ortolani test, the hip is dislocated, and we put our finger back here and just bring it out. And it'll pop the hip back in the socket if it's out. So the Ortolani test is just like this. And the Barlow test puts a little pressure backwards and then does the same thing.
So you can see that this is a very gentle test, and it's more of a toggling movement where you're lifting the hip into the socket instead of just spreading the hip. Now, it's not reliable all the time. Even Mariano Ortolani, when he published his book many years ago, he said the jerk sign, which is what he called it, can be elicited as long as the femoral head can exit, even partially, and re-enter the acetabulum. These conditions can always be found in hips with mild alterations, while in serious cases they are seldom noticeable. So a completely dislocated hip that's fixed in dislocation, can't be reduced, may not be detectable in a newborn because newborns can have full range of motion. Here's an example of a child with Pierre-Robin syndrome. That's the feeding tube, but otherwise the child is healthy and had a full range of motion. But you can see that both hips were dislocated. So we might not have found this if we hadn't been taking x-rays in general because this child had another syndrome. There was no sensation of reduction because the hips were completely dislocated. 1 in 5 dislocations is detected after 6 weeks of age, which is somewhat disconcerting. And the parents may tell you that the child has an abnormal limp. Here's a child with that limps that the parents had a video.
Good girl. You ready? Hold on, watch it.
So you can see that's not exactly a normal toddler limp. If the mother says the child's limping in a peculiar way, then it's worth looking at the child yourself.
Basket.
Late presenting hip dislocations, like we said, they account for 20% of all cases. Now, it's estimated that 10% of those were present at birth, but were undetectable by clinical exam, perhaps because they were fully dislocated and did not go back into the socket. But about 10% actually develop after birth. And several dislocated hips are now reported after a normal ultrasound at 6 weeks of age. So we do know that late presenting dislocations can occur, and that's a good reason to continue repeated examinations through the first year of life. So let's watch this video.
An unstable hip diagnosed in the first 6 weeks of life is usually considered to have been unstable from birth. It can be difficult to detect subtle instability at the first examination. Therefore, examinations are carried out regularly in this period by both medical and nursing practitioners. Instability may not be evident to examination in the first 6 weeks. These hips typically present at 4 to 6 months with asymmetry of the leg posture. The thigh and gluteal creases may be uneven. The leg may appear shortened, but most striking is the presence of a limitation of abduction, the ability to stretch the leg outwards. This later presentation is usually in a baby who has been examined at birth and at 6 weeks with no abnormality detected. The Barlow and Ortolani tests become less sensitive in the older infant due to the development of soft tissue contractures and the larger body size. At this older age, the detection of asymmetry is more important. Asymmetry may manifest itself in 3 ways: asymmetrical creases, shortening of the limb, and limitation of hip abduction in flexion. Asymmetrical creases are common at all ages, especially in neonates. They are a soft sign of hip dysplasia and by themselves are not diagnostic. Extra folds may be present in the thigh or gluteal regions. A dislocated hip leads to shortening of the leg and a bunching up of the surrounding soft tissues, often producing a deep fold in the gluteal region. In general, asymmetrical skin folds need to be appreciated in the context of the rest of the examination and seen as collaborative evidence rather than being absolutely diagnostic. Limb shortening may be due to a dislocation or subluxation. The best way to assess shortening is by the Galeazzi test. With the infant lying on a flat, firm surface and the pelvis level, both hips are flexed to 90 degrees and placed in neutral abduction-adduction. The levels of the knees in the vertical plane can be assessed, and any shortening of the leg due to a hip subluxation or dislocation will be visible. In this position, any asymmetry of the gluteal folds will also be apparent. For this test to be accurate, it is essential that the pelvis is level and the examiner stands at the end of the examination couch. The most sensitive sign of hip dysplasia in the older infant is a limitation of abduction in flexion. If this test is done well, even minor degrees of dysplasia can be detected. With the examiner standing at the end of the examination couch, both hips are flexed to 90 degrees. The hips are then abducted, slowly allowing the hips to gently stretch out. Asymmetry is detected by comparing the range of hip motion and assessing the degree of resistance between the two sides. This maneuver must be performed gradually, as many infants will find it uncomfortable, particularly if hip dysplasia is present. It may be best to repeat this test a couple of times, increasing the abduction each time, allowing the infant to become comfortable with the examination.
Now, there are other reasons for gluteal asymmetry, and one of them is an abduction contracture, where the leg is stuck out to the side. Infants that are in the fetal position have their legs crossed over, and one leg often has more abduction than the other. Now, when the legs are brought together, the pelvis tilts, and this raises the opposite side. So you can see this leg, the muscles on this side are tight, so when you bring the legs together, it shifts the pelvis upward and creates asymmetrical gluteal folds. This X-ray can be taken, and it seems to be normal. Both hips are reduced. However, this is a problem because the abduction contracture may actually shift the center of rotation of the hip, and if the hip's unstable, then bringing the legs together can lateralize the hip. It can produce a lateralizing force against the soft labrum cartilage. So an abduction contracture can lead to a dislocation, even though there's not one on the X-ray. Here's an example of an infant with an abduction contracture, and you can see that Shenton's line is intact. Here, the hip is in the socket, and it's nicely centered with the hip spread apart. But when the hip is brought to the midline, you can see that there's a slight subluxation. It moves out of the socket a little bit, and this Shenton line is broken. So that's due to an abduction contracture. There's really nothing wrong with this hip except that it's a little loose and it has an abduction contracture. So these need to be treated like DDH. Surprisingly, they need to be held in abduction until the hip becomes more stable. So basically splint and protect the hip to provide stability, and then allow natural recovery range of motion to occur after the ligaments have tightened up. So here are some examination difficulties.
Sometimes a neonate or infant cannot be settled enough to be sure that the examination of the hips is normal. In the first instance, warm and feed the baby and attempt the examination again. If this fails, it is important to document that the hip examination has not been performed and an arrangement made to review the hips at an alternative time or at the next assessment visit. The hips should not go unchecked on more than 2 visits without a clear plan being put in place to follow up the infant. The examination of large babies usually requires a minor modification to the examination technique. It may not be possible to get the fingers over the greater trochanter during the Ortolani test. Therefore, it may be better to hold onto the mid-thigh rather than the knee. In testing for asymmetry of abduction, the examiner may have to rely on feel more than look. A neonate with a fixed dislocation may have little evidence of asymmetry and a near normal range of abduction. This, combined with no signs of instability, makes for a difficult diagnosis. Signs of asymmetry are absent if both hips are dislocated. The examiner may recognize that the total range of abduction is reduced, or elicit an Ortolani sign on one or both of the infant's hips when testing for instability.
So here we are at this stage of our part 1. We've finished the anatomy and pathology and the clinical diagnosis. Now we're going to go to referral for imaging or treatment. This is the International Hip Dysplasia Institute referral pathway. It's adopted by other organizations as well. And it begins with the examination of the newborn. So we're going to work our way through this, as complicated as it may seem. But if you examine the child, and is the exam normal? That's the first question. If the exam is abnormal, then of course the answer is no, it's not normal. So we're going to go with a dislocated hip. If you think it's dislocated, you're going to refer it, and that one's pretty clear. So let's take away this normal exam side for a minute and look at that. Like we said, if it's dislocated, then it's pretty clear that you're going to refer it right away. Well, what if it's dislocatable or Barlow positive? Then you look at the age. So if it's mildly unstable, because like I said, this is not a normal exam to your clinical findings. So it's either dislocated or it's unstable by exam. And if the child is older than 16 weeks, then you're going to get an x-ray. But if the child is less than 4 weeks and it's unstable, then you're going to repeat the exam at 4 weeks, because a lot of mildly unstable hips will resolve. So you can repeat the exam at 4 weeks. Now that in-between age, if you repeat the exam at 4 to 16 weeks, at this stage, you're going to get an ultrasound in radiology or repeat the exam. If the ultrasound shows an abnormal hip, here's the ultrasound, you refer the child. So 4 to 16 weeks, an unstable hip, you get an ultrasound over here. If the ultrasound's normal, then yes, normal ultrasound, then you continue well baby exam. If you get the ultrasound and it's abnormal, then you refer to peds ortho. Okay, so if you're not going to have an ultrasound, you don't have access to it, there's no trained staff available, then you defer until 16 weeks of age and get an AP X-ray of the pelvis. So in some remote regions, an X-ray at 4 months may be suitable, because there's still time to treat the child. In Chile, the screening mechanism is that all infants are supposed to have an AP X-ray of their pelvis at 3 months of age. And in some remote areas, an X-ray is just perfectly fine. You just need to wait a little bit older so that you can see the X-ray. If you have ultrasound, then you get an ultrasound for an unstable hip. If you're uncertain, 4 to 16 weeks, you can get an ultrasound and then make a decision. Likewise, if the AP X-ray of the pelvis is normal, yes, then you continue your exam. If it's normal, no, then you refer to peds ortho. So you can follow this pathway, and it's available on our website. Now let's take the child, the exam at birth is normal, a normal exam. Okay, well then, if the child has this normal exam, the child has risk factors. If there are no risk factors, then you continue your well baby exams. But if the child has risk factors, then you go into this same pathway. You can repeat the exam, but at 4 to 16 weeks, generally, if there are risk factors, an ultrasound is recommended, and the decision is made on the basis of the ultrasound. If it's abnormal ultrasound, refer. If it's a normal ultrasound, then you continue your exam. So the risk factors are important. We're going to discuss those a little bit. The 3 that are most important are the breech position, the family history, and incorrect swaddling. Now here's what we know from the American Academy of Pediatrics recent evaluation and referral recommendations, or article really. They've taken away the guidelines to help with that, but they have suggestions. They say the important risk factors for DDH include breech position, female sex, incorrect lower extremity swaddling, or positive family history. And they're additive. So if you've got 2 or more, it's worse. You'll note that they added swaddling since the last time that guidelines were developed. Let's talk about the breech position, because there are different aspects of the breech position. There's a complete breech with the legs folded, incomplete breech, or frank breech. And there are different methods of delivery. Almost all breech babies in North America are delivered by cesarean section today. But a frank breech, this type, with a vaginal delivery, reportedly has a 47% incidence of DDH. So you can see that passing through the birth canal in this position can stretch the ligaments and stretch the hip and increase the risk of hip dysplasia considerably. Now, a complete breach like this with a vaginal delivery only has an 8% risk of DDH, but by C-section it drops down to 1 to 4%. That's still pretty high. So even any breech position, even born by cesarean section, warrants an ultrasound at 6 weeks, 4 to 6 weeks of age. And at any time during gestation, if the baby was in a breech position, it's been suggested that this can interfere with hip development. So breech at any time during gestation increases the risk of DDH. So we know that breech carries an increased risk, but with the cesarean sections being done today, the risk is much lower and there's no reason to frighten families. You just need to follow up on it. Family history we know is a positive correlate. A sibling with a confirmed hip dysplasia, there's a 6% risk that the next infant will have hip dysplasia. So that's about 1 in 16. Now, if the parent had confirmed hip dysplasia, not just hip pain or something along the line, parent with confirmed hip dysplasia, the infant has a 12% risk of DDH. So if the mother says, I was treated for hip dysplasia, then that's a child, even with a normal exam, you're going to want to get an ultrasound at 6 weeks of age. The parent and sibling, both, if they have confirmed DDH, there's a 1/3 risk that the next infant will have DDH. So these things are additive as well. Another factor is that if a child has had surgery for hip dysplasia, there's actually a 25% chance that another close relative has had hip dysplasia. That doesn't mean 25 per child, but any child that has hip dysplasia, somebody in the family will have had hip dysplasia, whether it's a grandparent, sibling, an aunt, or an uncle. Now, incorrect swaddling has been added as a risk factor, and this is primarily when the legs are extended and pressed together. The risk of hip dysplasia is about 1.5 to 3% in modern societies that still use swaddling. In some societies like Japan and Turkey, this has been decreased to 0.1% with educational programs. So tight swaddling, traditional swaddling for prolonged periods of time is definitely a risk factor. Here's a video that kind of shows how that can happen. That when the hips are brought together, it can force the hips out, particularly if the child had an abduction contracture. So tight swaddling with the legs together is not a good thing. The good news is that 97 to 98.5% of children are not bothered by tight swaddling. So this has been a difficult message in some societies because they say, well, all of the other children in the village were treated this way and none of them have hip dislocation, so it can't be related. Well, they're right most of the time, but you can decrease the risk by proper swaddling. And it is a risk factor if you have a mother who's done that consistently. Now, a recent study in 2017 showed that less than half of pediatricians educate parents and newborns on the risk and benefits of swaddling. So it's worth time to show them that they need to leave plenty of room for leg movement. And with a little bit of room like that, when they swaddle the upper extremities, but leave plenty of room for leg movement is all you have to tell parents. So what don't we know? This is from the same article. It says other suggested findings, such as being firstborn or having torticollis foot abnormalities or oligohydramnios, have not been proven to increase the risk of non-syndromic DDH. Still, although there haven't been large population studies, there certainly have been enough studies that show that these are related, and any of these things could be a concern. There's a documented increased risk of DDH in studies of oligohydramnios. There are 2 recent ones that show that up to 16% of infants that had oligohydramnios have DDH. When you find torticollis, 12 to 15% have been reported to have DDH. Infantile scoliosis is much more rare, but 4 to 11% have DDH, and even a severe calcaneovalgus foot, where it's pressed up, it's dorsiflexed and pressed against the tibia. So the severe calcaneophagus foot, not the club foot, but the opposite of a club foot, can have up to 6% DDH. And this is probably a packing phenomenon. So any of these features should heighten your awareness and maybe even consider getting an ultrasound. So the risk factors, 25% of DDH cases have risk factors, but that means 75% don't. So you certainly can't rely on risk factors. They're just a guide for another sense of awareness. Ultrasound imaging is warranted for infants with normal exam and risk factors. Infants with more than one risk factor are at much greater risk of DDH than infants with only one risk factor. So let's go back to this risk factors and the IHDI referral pathway. If there's normal exam and no risk factors, then you're going to continue regular hip exams, especially firstborn girls. But otherwise, they'll go into the pathway that we talked about. Now, there's a tool online that you can use, which is called Appropriate Use Criteria. And you can locate it at the American Academy of Orthopedic Surgeons. Look at the bottom here. You can Google AAOS Appropriate Use Criteria, and then find DDH management for generalists and referring physicians. Or if you want to pause this and write this down, you can go directly to that website. And you plug in the data, and it tells you what to do. It makes recommendations. So you can plug in the data, and it'll make recommendations for you. This is a wonderful thing. Kishore Mulpuri and his group put this together, and it's a remarkably useful tool. So now we've gone to the website for the American Academy of Orthopedic Surgeons. These appropriate use criteria, you have to check that you've read and understand the assumptions and disclaimer. That'll take you to this appropriate use criteria. So let's suppose that you have a 4-week to 4-month-old infant, and risk factors are present, and the exam is normal. Then we're going to submit that, and it'll tell you what your recommendations are. Obtain an ultrasound at 4 to 6 weeks of age, or upon presentation if older than 8 weeks of age. You can also continue physical exams and obtain an AP X-ray of the pelvis at 4 to 6 months of age. And if those are abnormal, then you refer to a specialist. Okay, let's say the baby is birth to 4 weeks, risk factors, and normal exam. This says obtain an ultrasound at 4 to 6 weeks of age, continue physical exams could be considered. Well, what if the child is 4 months of age? Now you're going to get an X-ray of the pelvis. So it tells you what to do. It's pretty simple. This is on the Academy website. So now we've covered most of part 1, including referral indications and pathways. There's one more item that I'd like to cover, which is prevention. We'll go through that briefly because it involves infant care practices that you may be able to advise your parents. First, teach proper swaddling. Leave the legs free to move, and this is less important after 4 to 6 months old. The first 6 months is when the hips are developing rapidly. So here's a swaddling method. We use the square swaddle technique with a square blanket. Place the shoulders at the edge of the blanket. Bring down one arm and wrap it over. Tuck it underneath. Bring down the other arm. Wrap it over. Tuck it underneath. Now, this baby's not squirming too much, but this really does calm them down. Then make sure there's plenty of room for the legs, and don't wrap this very tightly. You just fold it up and tuck it gently under the baby, but leave plenty of room for leg movement. It's as simple as that. This video is on our website, hipdysplasia.org. Now, tummy time is definitely important. There's a lot of information about back to sleep, tummy to play, but the tummy to play isn't as promoted as much as it should be. A German physician, Mao, in 1981 wrote about the 7-point syndrome due to inadequate tummy time. And the 7 points are plagiocephaly from inadequate tummy time, and combined with that is facial asymmetry, scoliosis, particularly infantile scoliosis and a flattened thorax, and hip dysplasia or buttocks asymmetry. And here we have the foot dorsiflexion that we talked about that is over here, be more severe than that. But those are the 7-point syndrome that Mao talked about. Now, tummy time helps develop the neck and spine muscles, and it improves achievement of motor milestones, and it decreases the risk of plagiocephaly and infantile scoliosis. This has been shown by many authors. So tummy time is very helpful for infants to get their strength and prevent these problems of their head and scoliosis. 30 minutes a day seems to be about right, but the AAP recommends tummy time 2 to 3 times daily for 3 to 5 minutes, about 15 minutes a day, increasing for a total of 1 hour over the first few months. The National Health Service in Australia recommends 30 minutes a day for infants. The problem is, as today's parent says, tummy time is essential for babies, but most of them hate it, and you probably dread it too. Now, 25% of parents are actually unaware of the importance of tummy time in surveys, and 50% say that their babies hate it. So is there an alternative? Well, there may be. Baby wearing. Now, baby wearing is becoming very popular for attachment parenting. It's different than infant transport. Baby wearing is not short-term infant transport, but it's wearing for normal activities several hours each day. The baby's on the mother's body. And the benefits are similar to kangaroo care in the early infant period where you do skin-to-skin contact. Baby wearing can promote bonding. There's plenty of literature on this, including a very interesting study from Canada where they had a randomized controlled trial in 2 separate hospitals. But it improves breastfeeding success, it calms the infant, and it allows hands-free activities for the mother. So most of the time while the baby's being worn, they're quite quiet and comfortable, and the mothers could work. Many of them can return to work, and the only time the child seems to be fussy is when he's hungry. The mom can take a little break and feed the baby and go back to work. So it's not as disruptive as it might seem with the mother wearing the baby for work activities. Now, muscle activity during baby wearing has recently been shown to be very similar to tummy time. This was a biomechanical study from the University of Arkansas by an innovative researcher named Erin Mannon. And she put some surface electrodes on babies and looked at them in various positions in tummy time, carrying, baby wearing, lying on their back, and in a car seat. And what they found was overall our findings indicate a crucial role in prone positioning and the muscle activity of the back and neck. The utility of baby wearing in an inward-facing, soft-structured baby carrier for neck muscle development, and the harmful implications of prolonged time spent in an infant's car seat. She actually concluded that the muscle activity during baby wearing is very similar to tummy time, and babies love it. So we don't know if that's a substitute for tummy time, but it certainly is an attractive alternative at this stage. And the benefit of baby wearing is it's also good for the hips. In the position with the legs spread around the mother's torso, or even in the infant position with the legs flexed in the fetal position, the femoral head is centered in the acetabulum. The muscle action of the infant gripping the mother's thighs actually pulls the legs against the mother's torso and improves development of the hip. So the biomechanics of this are that when the baby is being worn on the mother, it stimulates groin muscles, and the child grasps, and it helps hip development. Again, German researchers are way ahead of us on this, but it can help. Now, the early infant, you just put them in the carrier in the infant position, the fetal position. So there's not an exact position, but more flexion requires less spread, and less flexion requires more spread. So the newborn has his hips flexed fairly consistently. In cultures that do this traditionally, the Chinese, the Bantu, Nigerian, and all cultures studied, they rarely have hip dysplasia, and they rarely have hip arthritis as adults. So it may foster good hip development, and it may be an inadvertent prevention for hips that are unstable. So inward facing M position is best. The M position meaning that the knees are up, the butt's down. So this is the M. Now, as I said, as the child gets older, there's not a strict criteria, but the spread is desirable. And in the little infant, the legs can be even flexed more and less spread. Let's talk about screening at the end. Screening tests for DDH have limited accuracy. An incomplete rating was given to them by the United States Preventive Services Task Force, and it says insufficient evidence to recommend for or against routinely providing screening, mainly ultrasound. The balance of benefits and harm cannot be determined. So the Preventive Services Task Force just said, we don't know about screening, but until we do, universal or comprehensive screening of all newborns is not warranted. And I think most of us would agree with that. That doesn't mean you shouldn't examine the baby and do selective screening. They gave it an I rating, as I said. Now, in Germany and in Austria, they've done ultrasound screening of all babies. And it's expensive, and it requires technical expertise and equipment. And the big concern is it can lead to overtreatment with unintended complications. And most countries with nationalized health care do not perform routine infant hip ultrasound studies because it's too expensive and too complicated. The overtreatment issue was addressed by the United States Preventive Services Task Force because they said that overtreatment with a pelvic harness can cause avascular necrosis, which it can. But that's with real honest-to-goodness treatment. Now, Germany and Austria have taken a different approach. They've done this comprehensive screening, and they found dislocations in 0.2%, but they don't call it treatment. They've done prophylactic splinting for mild dysplasia. 7%, 1 in 14 newborn infants gets kind of a padded diaper and gentle spreading. So it's called prophylactic treatment. It's not called treatment. It's prophylactic splinting for the mild dysplasia. What they've shown is that early infant treatment or early infant prophylaxis has led to a 46% decline in pelvic osteotomies for adult acetabular dysplasia since the time they started doing this. So it does appear that prophylactic management may help prevent that late type of arthritis, and it's certainly helped prevent late dislocations that occur because of an unstable hip that was swaddled wrong or something like that. So there may be a place for padding. In fact, this bulky diaper method of prevention was required by law in Serbia in 1977, and it reduced the risk of late dislocations by 85%. So what I'm suggesting is we need a little more research about multiple diapers. Bulky diapers are probably not going to reduce a dislocated hip. Most pediatricians and doctors have been taught that bulky diapers have no benefit. Well, they probably have no benefit for a dislocated hip, but they may benefit the mild dysplasia, and that remains to be determined. So this has reduced the rate of dislocations in Serbia. In fact, similar results have been found in Canada with the bulky diaper. Treadwell's group in Vancouver found 62 infants with mild dysplasia by ultrasound. So these are babies with mild dysplasia who might have been treated, would have been followed and treated in a certain percentage with a pelvic harness. But they found 100% success without other interventions just by using a bulky diaper. So bulky diapers don't help dislocated hips, but they may help mild instability. Abduction pants are commonly used in Eastern Europe for the first few weeks of life. And you can see this is the depth of the acetabulum at birth. It's the shallowest at birth in order to allow the baby to pass through the birth canal. And it improves rapidly in the first year and then gradually in the next 4 years. So this first 6 months is the critical period of hip development. And for mild dysplasia, it may be worth investigating the use of bulky diapers. So in summary, the clinical exam identifies most unstable hips. The ultrasound at 6 weeks for normal exam with risk factors, torticollis, oligohydramnios, or severe foot deformity, not clubfoot. Any child that's done improper swaddling, we need to maintain proper swaddling. And my personal opinion, which is not borne out by evidence yet, is to consider bulky diapers or baby wearing for mild cases or prior to ultrasound for at-risk patients. So if you have a child you suspect I personally think it's okay to recommend multiple diapers. Advice for parents is available on our website, www.hipdysplasia.org. A lot of people go there. We have a list of hip healthy products, but that doesn't mean that there aren't a lot of them. There are a lot of hip healthy products that hold the hips in an optimum position. We have downloadable brochures for pediatricians. These brochures include swaddling, baby wearing, what is hip dysplasia, and preventing hip dysplasia. These are free. You can download them or you can write to us and get them. And we have educational sessions on board. You've seen some of it. This is from the Royal Children's Hospital, Melbourne. And search for teaching modules and you can see this whole module about diagnosis. It includes a segment on swaddling as well. There's an online quiz and you can test your own knowledge. And if you want to, come back someday and we'll do part 2, which is actually initial non-surgical management. This is where we can teach primary care physicians and healthcare providers about imaging interpretation, PAVIC harness, indications, applications, and management. Again, this is a validated teaching program, and you can be tested on it and get a certificate. Thank you again for participating, and thanks to the International Hip Dysplasia Institute for developing all of these materials.